This is Advanced Regenerative Medicine Institute. We're having a distinct pleasure of having Jesus Medina, my good friend, my brother. He's going to be talking today regarding orthobiologics and the treatment of chronic pain. Dr. Jesus Medina is my good friend. He's an anesthesiologist, pain physician. He is a world explorer, very artistic guy, very good humorist. But he's going to be giving us about a 30-40 minute talk today. We're going to start in a few minutes. We're just letting people trickle in. In the meantime, I'd like to throw a shout out there for our annual Evolve conference. This is going to take place in Salt Lake City this year, February 3rd through 5th, 2023. We've got world-class faculty as always. Aaron Kolodny, as many of you may know him, Andrew Trescott. These are legends in the pain space. Certainly Dr. Jesus Medina will be joining us. Bert Mandelbaum, who just got back from Qatar. He's an orthopedic surgeon, and he was the lead sports physician, team physician for the U.S. Soccer team. Amy Killen, who travels all over the world giving talks on aesthetics and sexual wellness, fantastic speaker. Matt Murphy, Rob Kinney, Christy Davies, Arthur DeLuigi out of Mayo Clinic, Jim DeCastro will be joining us as well. I just highly recommend you come and take a look at this conference. You can join us in person. We're going to have some hands-on practice, live PRP, BMAC, aesthetics, a lot of small group breakout sessions so that you can really get deep down into how these experts are practicing their craft. Coming back though to Dr. Medina, he's going to give us some talks on the cutting edge new studies on orthobiologics for chronic pain medicine and treatments. But in the meantime, let's see how many people are signed up so far. And we'll probably give it just another minute or so. Just want to also let you guys know that if you have any questions for Dr. Medina, you can punch it into the text box, and we will take care of those at the end of the session. This will be recorded, so if you can't stay for the entire thing and you'd like to hear it later on, it'll probably be posted on YouTube within the next 3 or 4 days. So let's see, how many people are signed up so far? Participants. All right, I hear people joining us. 16, 17 attendees. I know 160 something people have signed up for this, and they're going to be trickling in. So we'll give that a few more minutes. But if you'd like to learn more about Dr. Medina, his practice is out of 2 places. He's in Mexicali, Mexico, and Algodones. And it's the Medina Medical Specialties, I think, is incredibly impressive. I haven't gotten a chance to personally go down there, but they encompass the full spectrum of interventional pain management. There's also dentistry there. His brother's a dentist. They have dermatology. They have a pharmacy. It's the whole shebang. Quite impressive. If you have medical tourism dollars and you want to go down to Mexico and get your teeth done, you should look up Dr. Medina, the other Dr. Medina.
It's at least 40% less.
It's at least 40% less. Mention the code GCC and you'll get at least 1 shot of tequila after that.
A margarita. Free margarita if you say GCC sent you.
There you go. All right, Jesus, I don't know if you're ready to get started. It's 4:04. Why don't you take it?
Perfect. Thank you. Well, thanks. Thank you, George, for the invite. Thank you, Army, for considering me give this talk to you guys. This webinars that just amazing people giving these webinars, so it's an honor. So I'm just going to share the screen. Okay, right here. So today we're going to talk about orthobiologics in chronic pain, but we're going to focus on the soft tissue structures, like the bursas and chronic pain syndromes, or things that we usually don't think about in the office. You know, that's where I do most of my regenerative practice, in the office. Ultrasound guided is my number one way to administer these therapies. So we're going to talk a little bit about that. And well, my name is Jesus Medina, and I'm a past president for the SMOOD. Hopefully you can follow us on Instagram, SMOODMX. And of course, please go to these Evolve conferences. I think it's definitely made my practice way better in the regenerative area. There are definitely big players in that meeting. So I always come with a new tip. So let's start. So talking about something that really inspires me, you know, tensegrity. The first time I heard about that, was one of these talks with Aggie in the WIP. So it really hit me, you know, it really hit me how these the body is connected by these connective tissue fibers, you know. And tensegrity is the play of two words, tension and integrity. So if we take that in mind, we must understand that the body works differently than just the bone moving around. You know, it communicates. These fibers have a certain way of communicating. Sorry about that. So it's very interesting to take into mind this concept when we're thinking about regenerative medicine. So always take that into mind, you know, that if we're treating certain joint, let's say the knee, we must think if there is radiated pain or there's something going on the hip, or the soft tissue around the hip, the soft tissue around the ankle. So always take that into mind. So talking about fascia specifically, we know fascias have an origin, a mixed origin from ectoderm, mesoderm, endoderm. It's a mix of various layers. So these fascias is a group of cells capable of a response to biochemical signals. So it's not just a support structure, it also is a structure that can communicate, you know, with certain stimuli. It's discrete, localized, leading to the development of specific structural tissue. So something that I read, that is a metabolic kinetic field. So it definitely influentiates chronic pain syndromes, this structure, you know, fascias definitely influentiate, and we always must take that in mind. So I don't know if you guys do this, but usually when I have a talk, I just Google images, I put fascia, and this is what I got, you know. So it's a fascia, but as you see, it's unifying the roof with the solid structure of the house. So it actually is a fascia, the fascia of the house. There are also fascia in cars, you know. So over here in Mexico, the roads are not that great, so sometimes we hit the fascia with these big potholes. So we know a little bit more of that, but that's what I got when I first put fascias on the Google images. But then we got to this, you know. So we see this complex fibrin matrix from the skin to the blood vessel to the muscle. It got nerves, it's got mechanoreceptors, it's got a lot of nociceptive input. So the body is not a product of certain parts, but it's an organism that assembles, maintaining this union through all different fields. So these fields work together to maintain posture or absorb certain forces or certain gravity forces, or so this all works as a team together. So that's why when we consider treating a patient at a certain joint, that maybe that joint can manifest to another part of the body, you know, like referred pain. So like we see in the images here, we see, sorry, I don't, sorry, we just, okay. So we have this, it says the bone bag, but it's the skeletal muscle is part of it, but then we got all the whole myofascial bag around it, you know? And in the next image that we see how these interconnections, like we see from the iliac crest going all the way up to the fourth, fifth rib. So we always get these patients that hit, doctor, what hurts? Like everything hurts. My whole back hurts from my lumbar area to my cervical spine. And we're like, oh man, where do we start? You know, is the facet joint? Is it the neck? Where do we go? So this could explain a little bit of how we could spread out our treatments and like in rehabilitation protocols or physical therapy. I think they're much more familiarized with this than our anesthesia background, you know? So as you see, these fibers interconnect in a very complex way, and they disperse the tension so that the tension is not focused in one structure only. So these collagen bridges, you know, they even look like spider webs. So and these are French dissections of how, so we can understand how these big magnetic kinetic fields are also, as we see in the image, have blood vessels, have nerves, they have a function in that it's not just support. So we must take that into, and it's purely made out of collagen, so fibrin. So this regenerative medicines, this is a big target for us, you know, as regenerative medicine physicians. Talking about bursas, bursa is an extra-articular sac that its purpose is to reduce friction while sliding on soft tissue or bony prominence. There's native and non-native bursas. Native bursas are aligned with the synovial membrane, and we have them since we are born. You know, we are born with these bursas. And histologically speaking, the synovial membrane consists of two layers: a superficial layer that has synovial cells, and a profound layer that's a more thick fibrotic connective tissue that's very vascularized. So that's the difference in between the two layers. So when I hit bursa on the Google images, now I know there's a city in Turkey called Bursa. So for the next WIP meeting in Turkey, let's go to Bursa, you know, let's go visit Bursa. So I want to picture in those letters, you know, because it's kind of funny that you get certain things on the image, but what is a bursa for real? Well, histologically speaking, on the left side is a normal bursa. See this bursa, this connective tissue. We see these big gaps in between the tissue that helps this gliding motion. You know, that's a normal bursa. And on the right side, we see a pathologic bursa. It's actually a bursa from a greater trochanter pain syndrome. They have bursitis. That's actually a tendinopathy also, but the bursa does get affected. So as we see on the right side, we lost all this these areas of space where these keep the movement going. When we get a pathologic bursa, well, these spaces are filled with more fibrogenous tissue, and it has less consistency to the friction. So that's when all these impingement syndromes start, or this pulling on is not the same. This gliding motion of the bursa isn't the same like what we get in the subarachnoidal deltoid bursa. So a non-native bursa is a result of friction or overuse. It doesn't have a synovial fluid, synovial covering, no hyaluronic acid secretion. A distended bursa doesn't mean an inflamed bursa, usually is a thickened bursa. And in GTPS syndrome, greater trochanter pain syndrome, distension due to gluteus medius tendinopathy. So the origin is not a bursitis, but it's caused by this tendinopathy. So again, everything's connected, you know. I got a bursitis, but why is that bursitis? Because of the tendinopathy of the gluteus medius. And many bursas have intra-articular communication, but not every one of them. So recent histological findings have found and demonstrated nerve endings, nociceptors, and mechanoreceptors in ligaments and capsules. The stimuli to these endings permits recognition, nociception, and proprioception, minimizing excessive movements and abnormals that could cause an articular lesion. So it's not only support, but it also is like our brake, so we don't damage ourselves, you know. So the system is connected, but also has certain alarms that tell us, hey, this hurts, don't move it this too much because you're gonna get hurt, but really hurt. So this system works as a team again to provide the function of these complex joints, you know. It's not as simple as we thought. And talking about which bursas are like the most frequent one, well, I think everyone's treated a subacromial deltoid bursitis. So in the shoulder, that's the biggest one we have, and it's the most commonly involved in the pain syndromes. We have the subcoracoid bursa. In the elbow, we have the bicipital-radial bursa, the olecranon bursa. In the hip, we have the iliopsoas bursa, trochanteric bursa, ischiogluteal bursa. The knee has tons of bursas. We start with the suprapatellar recess, prepatellar bursa, infrapatellar, superficial, and deep. We have that bursa between the gastromyocnemus medial and the semimembranous, where we get those Baker's cysts. That's super common. The pes anserinus bursa and the semimembranous tibial collateral ligament bursa. In the ankle, we have the retrocalcaneal bursa, the retroachilles bursa, and the intermetatarsal bursa. We can also get adventitious bursas or bursas that are non-native because of friction down in those toes also. So speaking specifically about the shoulder, in this image, in the first image on the left corner, we have an interior seam of the bursas in the shoulder. So first we have that subacromial subdeltoid bursa, that big bursa with the arrows pointed to it, and we see how it extends, not always, from the outer portion of the humeral head beneath that coracoid process and in between the supraspinatus tendon. So we also have this in the arrowheads. We have the subscapular recess. So there's a bursa there also, and there's also the subcoracoid bursa. That's the arrow with a curve. So on B, we see a transverse image at the level of the of the joint, and we see again these bursas, but from up top, how it goes around the humeral head. We see that subacromial subdeltoid bursa. We see that subscapular recess, and that is the arrowheads, and that curved arrow is that subcoracoid bursa. And on C, we see the same thing, but at the level of the coracoid process. So we see that subcoracoid subscapular recess then with the arrowheads, and when they see again that curved the subcoracoid bursa on and how these things interact for an adequate movement. So those are all the bursas in the shoulder, and this would be like a young athlete with a subdeltoid bursa, subacromial subdeltoid bursa that is thin. There's no fluid. There's no thickening. So this is how it would normally look like. And this is a distended bursa. You know, we have plenty of fluid there. It's not that common to get that much fluid in that bursa, but it can happen, you know. So these are the bursas of the shoulder. Speaking about the elbow, we have two principal bursas, the bicipital radial bursa that goes around that bicipital tendon in the distal insertion. And it's a picture of the lateral elbow. And on the other one, on B, we have a transverse that's just distal to the elbow joint. And we see how this bursa goes around that bicipital tendon. And we see the olecranon bursa, the curved arrowhead, that can also be like in this image, it's a bicipital tendon. We see it's right on the arrowheads. And this hypoechoic area, it's the bursitis. And right on top of it, it's the nerve sitting on it. So these can be very painful. The bursitis can be severely painful, but we need to know landmark anatomy so we can get that orthobiologic safely to where we want it, and not maybe hit a nerve on the way in. And we also see this olecranon bursitis that's much more common in older patients. And I don't know if everyone has had one, that big bump on the elbow. It's sometimes common in these type of patients. Talking about the hip. So the hip, we see on the image on the left, we see a transverse projection at the hip joint. So we see this big bursa, that is the curved arrow, that's the iliopsoas bursa. We see the arrowhead is the gluteus minimus bursa. We see that squiggly arrow. I don't use that word that much, but it says squiggly on there. That's gluteus medius bursa. And the trochanteric bursa, the arrow on the bottom, where we see is one of the biggest bursa we have in that area. And then in the B image, we see the transverse at the ischial tuberosity. So we can see that ischiogluteal bursa. So again, all these work together, but which one is causing my symptom, or do I need to treat every bursa? So here we see on the image on the left, we see iliopsoas bursitis. And over here, we see greater trochanter pain syndrome, or a trochanteric bursitis on the right side. So talking about the knee, again, like I told you, we have many bursas in the knee. Like the R is the recess of the suprapatellar recess of the knee. So any injection we want to do intra-articular, we can do it there, and it will spread into the joint. We have this semimembranous and medial gastrocnemius bursa, where we get that commonly found Baker cyst, and that can really cause a difficulty in our patients because of nerve compression. And so sometimes we get patients that have symptoms that are irradiate up to the leg because of this Baker cyst. We also have this collateral ligament bursa, and with the pes anserinus. So as we see in the image on the corner on the right, we see that the tendon, that's the arrowhead, and we see this bursitis around the tendon. So it's really clearly to see what we want to treat. And if we want to treat it with orthobiologics, always do ultrasound guidance. Like this is a pes anserinus bursitis, is a massive amount of fluid for this area, but it could happen. It could happen with trauma. I don't know. It could happen in patients with severe osteoarthritis. We also have on the image on the right, we see this profound infrapatellar bursitis. So it's a tiny bursitis. Sometimes we see big bursitis, sometimes we small bursitis, but we need to treat everything. So maybe when we think about treating the knee, we need to think about all these components that take place so we can look for it. Like here is a superficial infrapatellar bursitis, and here is a superficial prepatellar bursitis. So there's many bursas, and every bursa can give us symptoms. Now, here's Baker cyst. This is one of the most common I get in my practice. It is like very rewarding, like taking away that fluid, and the patient just gets up and like, boom, where's my pain? Or pain is like diminished a lot. So it's very common. It's common that if we have more than 5 cc's or 10 cc's of fluid, it really is very common that it happens again. So we have to really tell patients that they should really rest, maybe put a bandage on a knee strap, something that helps us not distend again. Talking about the ankle, in this lateral picture, we see the retrocalcaneal bursa and the retroachilles bursa on this image. So this is, as you see, it's not only one or the other, it's both. So we need to treat both. And why is that happening? Well, maybe there's a callus, maybe there's a hot lung syndrome, maybe there's something going on with the tendons inserting on that point. There's definitely friction going on there, and this friction is not being dispersed by these bursas. So we also see on the other image, intrametatarsal bursa. And obviously it's full of a lot of fluid. There shouldn't be fluid there. So we get these symptoms. We maybe see, well, a scan, maybe it's a Morton neuroma, but no, maybe it's a bursitis. So I think those are treated differently, or at least maybe we're going to get a better result with regenerative medicine on the bursitis than the Morton neuroma, but who knows. And again, the calcaneus bursa, and we see, we see a calcaneus and we see this retrocalcaneal bursa, but very severe, Here, usually are patients with what they call Hadlung disease. So the suprachromosomal deltoid bursa is one of the largest bursas in the body. It's beneath this coracoid acromial and arch and the deltoid. It reduces the friction between the rotator cuff and this coracoid arch when we do the shoulder movements. But it not only lubricates, but also sends information of proprioception and through these mechanoreceptors. So starting with the studies, this is a very interesting study by Dr. Ide in Japan. They investigated the existence of sensorial nerve endings in the distribution that they had with silver tint. They also did immunohistochemistry studies to see if they got positive substance P or CGRP in 10 patients. So they resected a bunch of bursas in these patients and without shoulder pathology history. So in the image, we can see what the arrows are saying is this is a plexus that is formed, that tainted with this silver, forming a plexus on the roof of the bursa on the coracoid side. So there is nerve endings in the bursa, They also found Pacinian corpuscles. As you see, is a multilaminated area, and the taint is right in the middle. So, and it's around the fatty tissue in that area. So it's very close to the bursa, and these are mechanoreceptors that are sending information about what we talked about before. The Ruffinian nerve endings, these are like more like sprayed out, all over that area. And these are like quick adaptive response mechanoreceptors that again send information like vibration and all these forces that are involved. So there's many receptors that send different information for each aspect that we need in the body. And they also found like nerve bundles that go from the coracoid ligament. So nerve endings from the ligament to the bursa. So there's a bunch of nerves around this area, that we could treat or that we maybe could focus on with certain other therapies in combination with regenerative therapy. So in this study, they found 3 nerve endings, Pacinian corpuscles, Ruffini endings, and 2 kinds of unclassified receptors. The study confirmed presence of substance or taint of substance P in the suprachromosomal deltoid bursa, specifically in A beta and C fibers from the nerve ending. So it does have a capability of transmitting pain, So this is the distribution of these nerve endings, and they divided into 4, like supralateral, supromedial, inferior lateral, inferior medial, right next to a coracoid process and the great tuberosity. And as you see in this study, they found that this is an old study, like 96. They found that the supromedial aspect of this bursa or of this area is rich in nerve endings and different type of nerve endings, not just one type of nerve endings, but all over the area we have nerve endings, but mostly focused on that medial superior quadrant. So the Ruffini mechanoreceptors are slow adaptation receptors, and they are stimulated by displacement of collagen fibers in which these nerves intertwine. So imagine you get a stress on that collagen fiber, it's going to stress that nerve also. So the ligaments hurt, per se. There is sensitive to stress over the capsule and signalized joint position and velocity of movement. The Pacini dynamic mechanoreceptors are a quick adaptation, respond to mechanical displacement, pressure, and vibration. So when we have an accident, like in the gym or a car accident, all these structures are playing together to tell us what's going on. So these mechanical receptors send information necessary to control this balance and muscle force when the arm is raised. So it's complex system. This other study of 2008 by the Biomedical Research International, this is an interesting study. They're trying to find the anatomy and the innervation of the subacromial bursa. So what they do is inject blue gelatin 2 centimeters below the greater tubercle, and they focus on the subacromial bursa distribution of sensitive nerve toward the bursa and the size and location of the bursa. They dissected, I think, 11 cadavers and 18 bursas. And this is what they found, a very interesting find. So the pictures are very amazing, So sorry about that. They divided into quadrants, A, B, C, and D. And this is a lateral aspect of the humeral head. And we see this subacromial subdeltoid bursa, in this case, in this picture, doesn't communicate or doesn't go beneath that coracomial arch. So this happened most of the times in the bursas they tainted. It didn't communicate intra-articularly, or it didn't go beneath that coracomial arch. So as you see on the image on the left, it's not going over that point, but we see the image on the right that it is going inside. So that is interesting to see, because maybe some patients develop the bursitis with more intra-articular pain than others, but still an impingement syndrome. It's still a friction that's going wrong. So talking about the innervation of the bursa, they found an arterial branch of the axillary nerves that runs directly to the mid portion of the deltoid, giving off a sensitive nerve to the bursa. And as you see in the image, we can see those big yellow arrows. This is the anterior branch of the axillary nerve, and it gives off on the arrowhead this tiny sensitive branch to the bursa directly. So that's what they saw was more common, that there was a tiny sensitive branch come from the axillary nerve. It was mostly innervated this way. And as you see, they saw that the bursa wasn't communicated in 89% of the time. Only 11% of the time was communicated and went under that coracomial arch. It's an oval shape usually. 83% of the time, like I told you, it's innervated by the axillary nerve, and this 11% of the time, the branch originated directly from the posterior cord of the brachial plexus, like we see in the next image. So as you see, from the axillary nerve is a very short distance, but from the posterior cord to the bursa is a very big distance. So these nerves that are so tiny, like in big surgeries, like sometimes they must get hurt, by distension or by compression or by manipulation. So it's very interesting how the study painted out how we can see a bursa, of what we imagine. Sorry about that. So on the image we see, like the A, that 75% of the time is the axillary nerve on the lateral inferior and lateral superior portion of the body, and that of the nerve, axillary nerve, gives this branch to the subacromial bursa. And in the middle image, we see that sensitive branch going from that posterior cord. And in the right image on the corner, we see that they have both, from the axillary and from the posterior cord. So it was much more common on the axillary nerve than the posterior cord, or than together. That was way more rare. So talking about specifically platelet-rich plasma injections with needle tendinopathy for the gluteus medius tendinopathy. There's another tendinopathy that is very common in my office. So what they did this study is prospectively assess the efficacy of intratendinous PRP for the treatment of gluteus medius tendinopathy. The inclusion criteria was moderate to severe lateral hip pain, more than 3 months, refractory symptoms to conservative therapy like physical therapy, and gluteus medius tendinosis moderate to severe, and partial tear on the MRI. And it was very important to have a negative neurological exploration, so that everything was going fine, but like the adduction of the hip, that one could be an issue because of the same pathology, but no suspicion of radiculopathy or spinal involvement. So what they did, they pulled out 60 mLs of these patients to with 3 to 4 mLs of a leukocyte-rich PRP. They use lidocaine, the soft tissue structures on the skin overlying. And that's a very important part. And one of the studies George participated in is the effect of local anesthetics on the PRP. So in my personal practice, I do skin and subcutaneous tissue, but intratendinous injection, I try to avoid the local anesthetic or avoid the graft of cells have contact with that local, you know. Well, they use ultrasound guidance injection to go to these what I call areas of opportunity, hypochoric areas or tender regions of the greater trochanter. They did a needle tenotomy of the hypochoric regions of the gluteus medius tendon. They indicated rest for 2 weeks, no NSAIDs for 6 weeks. I preferably stop NSAIDs, period, unless like it's very, very necessary. And they did a rehabilitation program consistent of core stabilization, that's super important, hip abductor strengthening, and balance training. So this is the results they got on different hip scales. I did not know that these many hip scales existed. You know, that's new for me also. So they have this hip scale from the hip outcome scale for daily activity living, the hip hip score, the first one, the hip outcome score on daily activity, the hip outcome score on sport activity, and the IHOT-33, that is the hip outcome in the test 33. So what they saw is these measures increased significantly when PRP was applied once, and they did this tenotomy and they did this rehabilitation program. So in the image, we see where we were at pre-injection, we were at post-injection. So these functional outcomes, I think, are very interesting in some of the symptoms and the syndromes that are specifically soft tissue structures that are causing the pain, and that maybe we always go to the back, we always go to the MRI and see a lumbar disc that slipped or there's a nerve compression, and sometimes it's just a gluteus medius tendinopathy, but it can be really bad, really bad. There's also this other study about scapulothoracic bursitis. You know, this one we don't think about it that much. But if we think about all these patients with cervical conditions, thoracic conditions, or kyphosis conditions are very, very propense to develop this type of bursitis. You know, I know, or people who have this big exercise, everybody's big on exercise right now. So these bursitis are more and more frequent now. So we know that the scapula, it should helps us for an adequate smooth shoulder movement. And this scapula must glide through the thoracic posterior wall freely, you know, but there's no joint, you know. Some patients develop mild symptomatic, others suffer like severe pain and poor shoulder movement because of the scapulothoracic bursitis or snapping scapula syndrome. Excessive anterior angulation or supromedial scapular angle, abnormal spaciocapital lesions in the scapulothoracic space can make people more propense to develop this type of bursitis. Elastofibromas, fibrotic bursa, because it caused this mechanical crepitus that people can hear, you know, they hear it, and sometimes they don't hurt, but they just hear it, but it's just, I think, an amount of time until it starts hurting, you know. So we know the scapula is a large triangular bone that's concave on its inside anterior surface. It spans from the 2nd to the 7th rib, 5 centimeters lateral to the spinous process. And its primary functions is provide stability for humeral rotation and dynamic positioning of the glenoid fossa. So it's super important for shoulder movement. Again, tensegrity, everything's connected, shoulder with scapula, scapula with the neck. So shoulder movement is much more complex than we think, it's not just the glenoid and the acromioclavicular joint, the rotator cuff. It's many ingredients that take place in this this pain soup, So there's the scapula has like many things in the body, a very high variable osseous topography. There's no direct bony joint articulation. So appropriate dynamic scapular positioning requires a coordinated effort from the pericapsular muscles around this area. So there's two principal bursas, infraserratus bursa, supraserratus bursa. They're obviously divided by the serratus anterior muscle. So infraserratus bursa allows gliding between serratus anterior and thoracic cage, and the supraserratus bursa allows gliding between subscapularis and serratus anterior muscle. So symptoms that occur on the inframedial angle most commonly are caused by a pathological infraserratus bursa. In the supremedial angle, we can suspect of both, and pain near the medial confluence of the scapular spine may be caused by pathological scapulotrapezial bursa. So in the image we see on the left, we see this first circle. If we get patients complaining of pain in that area of the scapula, we could think about the infraserratus bursa. If we get more on the midline, maybe a little bit more south, we could think of the supraserratus bursa. And we think right at the medial level, right where the spine of the scapula is, we could think about scapulotrapezial bursa. And right there on the corner of the bottom, this is a common, this is like the most common I've had, the infraserratus bursa. And on the left, on the right, we can see an axial cut of this area and how these bursas interact with these muscles and how there's no joint between the scapula and the rib cage. There's just a big pack of muscles and bursas and fat that together in combination make the movement of the shoulder freely. So I just wanted to, I'm gonna read this, but just want to take a look all the origin of these muscles, where it comes from. It comes from scapula, and where does the other ones insert? So these muscles, that we've heard about, the supraspinatus, infraspinatus, teres minor, trapezius, serratus, all have or origin or insertion in the scapula. So scapula is important for shoulder movement, shoulder pain. We should always check this area, maybe palpate this area. Maybe we have a better response to our orthobiologics, because of course we can have the best orthobiologic, but again, if we don't have a diagnostic, or we're not thinking about tensegrity, or thinking about the communication between these fibers and the joints, well, maybe we're not going to be that as successful as GCC. If this guy knows his stuff, so he's we want that level. So talking about pathophysiology, of course we know there can be a scapulothoracic bursitis because of direct trauma, abnormal motion between the scapula, and usually like overuse injuries, patients that work in assembly lines can get that very common. There can be chronic inflammation, brucifibrosis, recalcitrant bursitis. So what happens? They get significant pain, they start guarding, they don't move it, and then they get muscle atrophy. So then the scapula directly articulates with the rib cage, like we saw in the image. So we don't have any muscle, so it's like rim on the road, no more wheel. So that gliding thing, it's each time much more difficult for our patients and much more painful. Patients with scapular rib fractures are much more propense to have scapulothoracic incongruence. So these patients are very common to have these pathologies. Structural spinal abnormalities like kyphosis, scoliosis can also develop these type of conditions. Osteochondromas, and again, elastofibromas also could be someone that could explain these symptoms. So again, can be mild to severe presentation with an audible snapping, but it produces a notable shoulder dysfunction. That's pain in the supremedial angle, can be minimal or excruciating. Scapular noise distinctly audible or only detected by palpation. So there's this sensation of crepitation. So it can be a lot or low, like a lot of pain and no audible, no noise, no, or it can have many types of presentations. Now, what do we check in the physical examination? Of course, first posture, see if there's any scoliosis, evaluate the cervical spine, rule out there's any referred pain, asymmetry, winging or audible snapping between both scapulas, palpation around the scapulothoracic joint reveals area of tenderness, potential infrasparatus bursa, suprasparatus bursa. We must test individual pericapsular muscle strengths. That way we can determine if these muscles are working adequately. We can also have what they call the SIC. It's a scapular malposition, inferior border prominence, anterior coracoid pain, and scapular dizziness. So again, this is a whole system that takes place to move our shoulder joint. Speaking specifically in this newer study in 2021, they were talking about bone marrow aspirate concentrate. Personally, I do bone marrow aspirate concentrate, but they were talking about bone marrow aspirate clot. Usually, I don't know, whoever does the bone marrow aspirate concentrate, we use anticoagulants to try to avoid that clot. But in this study, these Brazilians have a very convenient idea of why don't we use a clot? What does a clot offer us for our orthobiologic treatments? So talking about coagulated BMA potential applications, well, as we know, rapid coagulation is due to megakaryocytes, platelets, and coagulation factors. The clot formation is seen as a technical complication. People who have done BMAC, we've seen that if we don't act fast or there's not enough anticoagulant, we will get that clot. So on the biological standpoint, this clot may perhaps enhance regenerative mechanisms. Platelet degranulation required for coagulation, so there's all these growth factors there, which delivers numerous osteotrophic cytokines and growth factors. And we know that the fibrinolytic cascade benefits from this cell engraftment. So studies have cultured the BMA clot and its coagulated and non-coagulated states. 15 days after this culture, BMA clot, they displayed higher growth of kinetics of MSCs in comparison to the ones treated with anticoagulants. So it's a biodegradable scaffold that promotes chondrogenic regeneration, improvement in cell adhesion and proliferation, and superior DNA con-expression of these genes like SOX9 and RUNX2, these weird names, that highly expressed during chondrocyte or osteoblast proliferation, with the clot. So these MSCs are cultured in this fibrin gel display enhanced proliferation potential. So the BMA clot appears to offer significantly higher concentrations of all these growth factors, VGF, BFGF, IGF, SDF, and HGF. These cells are treated compared to the cell treated with peripheral blood. So it's logically BMAC and hyaluronic acid plus fibrin groups exhibited significant chondrial regeneration in rabbits' knees. It was a study in animals. And a combination of hyaluronic acid and BMA could stimulate proliferation. So maybe what they did is they used this lure lock and combine the clot with the hyaluronic acid, and we're going to see an image right next to this. And they saw that the BMA matrix could be enhanced with low dose of HGH, human growth hormone, or even glutathione that's a potent antioxidant. So what they did is use this lure lock and mix hyaluronic acid with this bone marrow clot, and they got all this matrix to work with, and with all the properties that I talked about before. So they took out the bone marrow and they let a clot and mix it up with the hyaluronic acid. They did not say how they injected it, but it's interesting area of opportunity, probably, you know, that maybe, I don't know, maybe in low income countries that we don't have all these systems, that the closed loop systems for BMAC, that it's something we could maybe consider, you know, or consider combining with hyaluronic acid to potentialize our proliferation effects. This other study is amazing, you know, because they combine something as wonderful as pulse radiofrequency with orthobiologics and thinking, is there a synergistic effect with this? So as we know, the proposed mechanism of action of pulse radiofrequency for pain is a decrease in pro-inflammatory cytokines and an increase in cytosolic calcium concentration that stimulates our immune system. The properties of orthobiologics focus on release of growth factors, stimulus of endogenous repair, analgesia, and improvement of injury. So the hypothesis of this study was a synergistic effect with the combination of both techniques, pulse radiofrequency and orthobiologics, with more benefit to our patients' quality of life related to pain. So they talked about this brain-derived growth nerve factor that could play a critical role in determining why that PRP-PRF association would be a good idea. They say this BDNF is involved in anti-hyperalgesic effect mediated by pulse radiofrequency and the DRG. We know that BDNF is a neurotrophin family of growth factors, NGF, neurotrophin 3, and NT4-5. So these guys, these neurotrophins are involved in the synapses and the formation of neuroplasticity. So it's an important thing to consider these substances, you know, and these are involved or outside the nervous system. There's many neurotrophin receptors expressed in the tissue, skeletal muscle, bone, immune system, cartilage, synovium. So what do these do? Promote anti-inflammatory and immunomodulatory effects. So all that with orthobiologics, I think it will get along well. So PRF is better described, or there's more studies in neural structures. But there's been some studies with promising effects on other tissue, like 2016 study by Yuan. They did 42 patients and compared pulse radiofrequency with corticosteroid, and there was more improvement in functionality and pain in the PRF group. In 2007, Slujiter published PRF for arthritic pain in refractory cases, reported good conditions in mobility and pain, and a follow-up for I think about 3 years. Migno and colleagues combined in vitro PRP and PRF, because that's a question also. Does pulse radiofrequency or this pulsing of electric energy, would it affect the orthobiologic per se? And they saw that no, there's no function, no impact in the functional integrity of platelets, and actually could cause enhancement in healing. So this is what their hypothesis is. Combine these orthobiologics with pulse radiofrequency to obtain this possible synergistic effect. That way, getting a better analgesic effect. We all know PRP hurts. Whoever does it, I always tell a patient it's going to hurt the first week. Improvement in function, modulation of inflammation, and tissue repair quicker. So that's something to look into. You know, I think everyone has a pulse radiofrequency or a machine that can give pulse radiofrequency that are doing orthobiologics. So that's gracias totales. Thanks, George, for the invitation. Thanks to Advanced Regenerative Medicine Institute for this launch talk. And just want to congratulate these guys on these webinars that are amazing. And I hope you liked it, you know.
Thank you, Jesus. That was amazing. You know, you did a really good job on a tough talk, and I think someone threw you a little bit of a loop on a structure that a lot of people ignore, right? People think of bursas and not to poo-poo the surgeons, but a lot of times they do these decompressions. they'll cut out that tissue and just sort of, oh, it's inflamed. Yeah, exactly. They cut it out and they think that that's the best thing. But it has so many functions in the human body, right? And, the sensory fibers, the proprioception, all that plays into it. It's not just for reduction of friction. I think you did a great job. You brought up some really good points. And also how to combine conventional pain interventions, right? There's always this debate between the destructive things that we do in pain versus the regenerative things that we try to do, right? The anabolic versus the catabolic. A fantastic job.
Let's work together, and I think I tell this to my patients. There are two different targets. One target is regaining strength, giving back, and the other one is denervating, or if you do cry, oh well, it's less, so this last study, it opened my mind, so thank you for giving the opportunity to share with you guys, because that way I'm pressured to go and look for more, or look for better studies. So it's an interesting field. It's growing.
So I'm looking here at the questions, and there's a question from the audience asking about bone marrow. And, I think people, it's interesting because I've looked at this extensively because, what are the things that affect our studies, right? You mentioned the review that we wrote, looking at the different biologics and the different cells, and how does lidocaine or contrast affect those cell lineages, and how does it affect their ability to express growth factors and whatnot. And I was not familiar with that study that you pointed out with the bone marrow. But the question here is, has that changed the way you obtain bone marrow? Because you had said, like, usually we add heparin to it, so that, because it's very sticky, right? If you don't add heparin to it, your entire system, your blood will clot up almost exactly instantaneously. Has that changed your practice? Have you considered, letting it clot and utilizing that clot as a maybe like a glue?
To be honest, I'm still using anticoagulants, but it's definitely a thing I would like to explore, or at least what I do, or that's similar to that, is that I mix my BMAC with, and I also get PRP from that sample. So I do my BMAC and I obtain a little bit more sample and I do PRP. So we know that PRP is going to be more powerful per se than the peripheral blood PRP. So I mix these two guys together, this BMAC with PRP, and I tell my patients it's like sending soldiers there with food, that if you would send it without food, so it's gonna help create this scaffold or this base where these cells are gonna stick to the tissue and maybe even immunomodulate, because the immune response is important, because we don't want our immune system like, hey, what are these cells that they are injecting in us, but definitely I have access to growth hormone. It makes a lot of sense. Growth hormone definitely is a stimulant. So why not use it with PRP, or just it didn't say the dose, but it says a small amount of growth hormone. So I don't know, maybe it takes the price up a little bit, but it maybe won't hurt, maybe we get good results like GCC with that.
Listen, I think that's really exciting, and obviously it's a little bit controversial, and it's difficult here, right? I mean, there's an evolving field where people are talking about biohacking, right? What does it mean to biohack, right? How do we crack the code? How do we kind of get into the software beyond the big hardware stuff, right? How do we get into the nitty gritty of the human body? And we're not trying to, we're not talking about HGH and some of these anabolic things, like, we're not trying to look like Arnold Schwarzenegger or Ronnie Coleman, right? We're talking about microdosing to augment the healing process, right? And it's interesting, I do see some pro players, right? And I've had them ask me about these things. And obviously, as the controversies in the professional baseball and things like that, and so they crack down on that. But their stakes are really high, right? And I have had these guys ask me about, these anabolic things. And they're saying, listen, I'm not trying to get, look like Ronnie Coleman, but I just see if I can use this to augment my healing. And some people are doing that. Do you guys do like bioidenticals down in the Medina clinic? Like, do you guys do testosterone and
that's a very popular technique, like the pellets and all these things that work for like enhancement or anti-aging properties. It's a very popular treatment, but to be honest, I've never used a growth hormone like they use it in the sports area, because they're using like high doses, like very high doses. But in the study, is adding a bit of this growth hormone to your injectate. So I don't know. I'm definitely gonna try that one.
Okay, I like that. So I don't know if anybody else has any questions. You can type it in right now. I'll give you like 30 seconds to throw that out there. If not, I'd just like to point out again, if you guys would like to meet Dr. Medina in person, or if you'd like to come and join us, we have a fantastic event program scheduled February 3rd to 5th in Salt Lake City. You can bring your ski boots, prepare for the snow. It's a fantastic time to be in Utah. Have a great lineup. We have Burt Mandelbaum coming out. He's the big hot show orthopedic surgeon at the Cedars-Sinai. He's also the U.S. team doc for the soccer. They just got back from Qatar. Arnold Kaplan won't be able to join us this year, but he'll be making an appearance. Jim Castro out of Philippines, Amy Killen, Shane Shapiro, Andrew Trescott, Matt Murphy, Rob Kinney, just an outstanding cast, Joel Baumgartner, Shane Shapiro, etc. So I hope you'll join us. Come and take a look. It's really inexpensive meeting in the first place. It's meant to really bring people in and bring people together to discuss things that we're passionate about. But I believe it's only like $1,200, and there's a promo code right now. If you sign up within like the next 4 or 5 days, flash 300, and it'll give you 30% off. We're going to have live patient demos. There's going to be an arm for medical aesthetics, doing live demos on and how we treat patients for orthobiologic injuries. I think I've got a couple of patients I'm going to be treating. Anyways, I hope you'll come and meet us, see us there. A hands-on workshop on Friday and Saturday. So thank you all for joining us. I know it's an awkward time on a Tuesday afternoon. So have a great night, everyone. Thank you, Jesus. Oh, look at that. What's it? Santa.
Merry Christmas. Feliz Navidad.
Feliz Navidad. All right. Thank you, everybody. Have a good night. Take care, Chewy.